Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues and PGs, a couple of months ago, I shared the part 1 of my lecture on how to keep cirrhotic patients alive. Today, I am sharing the part 2 of the series that how to keep cirrhotic patients alive. And in this lecture, we shall see that what measures should be taken to keep patients in child class A or in compensated stage. And when a patient comes to us in a decompensated stage, what should be our protocols, what should be the management plans to treat that decompensatory event and push them back into child class A. The topic assigned to me is how to keep cirrhotic patients alive. This is the main question in the clinical hepatology across the globe. I understand the audience in today's symposiums are the primary care physicians, the postgraduate residents, house officers, medical students, consultants from the internal medicine, and young gastroenterologists. So, in the next 20 minutes or so, I'll give you an overview of the concept that what measures must be taken to keep cirrhotic patients alive, to improve their morbidity and reduce their mortality. To answer these questions, we need to understand the 4 stages of the disease. The cirrhosis starts as a non-cirrhotic chronic liver disease. This is the first stage of the disease and characterized by the normal portal venous pressure, which is less than 5 millimeter. The patient has got normal lifespan, and when we see the liver status, there may be no fibrosis, or the fibrosis may range from F1 to F3. This phase is asymptomatic, and patient has got a normal quality of life. Remember, these patients are not immune to develop hepatocellular carcinoma. They may develop hepatocellular carcinoma, especially in the chronic hepatitis B cases. Then the next stage of the cirrhosis, which is the proper cirrhosis disease, it's the compensated liver cirrhosis. And this is characterized by the portal hypertension. The portal vein pressure, which was normal, the non-cirrhotic stage, now it has increased and it has become the hypertension level, and it is more than 5 millimeter. The median survival in this group is 12 years. And when we see the liver has got now F4 fibrosis and regenerative nodules, while in non-cirrhotics, the liver may be having no fibrosis or and maximum F3 fibrosis. Just like non-cirrhotic chronic liver disease, the compensated liver cirrhosis is also asymptomatic, and the patient has got good quality of life. But remember, in the second part of the compensated liver cirrhosis, the portal hypertension exceeds 10 millimeter of mercury, and then it is called clinically significant portal hypertension. And this is the stage when the varices develop. Again, this stage is not immune for hepatocellular carcinoma. Rather, the risk of hepatocellular carcinoma is increased as compared to the non-cirrhotic chronic liver disease. The third stage of cirrhosis is the decompensated liver cirrhosis. This is a stage characterized by clinically significant portal hypertension. It's more than 12 millimeter. And the median survival, which was 12 years in the compensated liver cirrhosis, decreases now to the 2 years. And why we call this decompensated cirrhosis? Because in the patient with compensated liver cirrhosis, four main complications may occur, and these may occur as individual complication or a group of complications or a combination of complications. And these complications are ascites, variceal bleeding, hepatic encephalopathy, which is episodic, and jaundice. Ascites is the most common complications which make a compensated liver cirrhosis as a decompensated liver cirrhosis. Variceal bleeding is the second most complication. Remember, in the compensated liver cirrhosis, varices develop when the pressure is more than 10 millimeter, but when this exceeds 12 millimeter, then these varices, they rupture. So development of varices does not make a patient decompensated. This is the variceal bleed which makes a patient decompensated. The other complication is hepatic encephalopathy. Jaundice is another complication. So these are the four main complications which make a patient as a decompensated one. As said before, the varices rupture when the pressure is more than 12 millimeter, and this is a stage when liver transplant is required. Hepatocellular carcinoma is the highest risk in this group as compared to the compensated cirrhosis and non-cirrhotic chronic liver disease. The next in the last stage of the disease is end-stage liver cirrhosis. The portal hypertension is extremely high here, more than 20 or even 30. The median survival has now decreased to 2 months. And when we call this, or when this stage sets in, when the ascites, which is diuretic, sensitive or responsive, it has become refractory now. Or the ascites has been changed into spontaneous bacterial peritonitis. It has become infected. The variceal bleeding, either it remains uncontrolled or the patient rebleeds and rebleeds. The hepatic encephalopathy, which was episodic in the decompensated liver stage, now it has become persistent. And the acute and chronic liver failure is another complication which makes the disease as end stage. Remember, this acute and chronic liver failure can happen in any stage. It can happen here when there is injury in the chronic liver disease, like acute hepatitis E or drugs. In compensated cirrhosis, it can happen here. In the decompensated, yes. So the acute and chronic liver failure, if it happens in the non-cirrhotic chronic liver disease, it will change the patient's scenario stage from non-cirrhotic to end stage is on a fast track. Similarly, the compensated liver cirrhotic patients, if they develop acute and chronic liver failure, they will be a fast track to the last stage. The other complications in the characterized with in the end stage liver cirrhosis are the bacterial infections other than SBP. So the liver transplant is required here, and again, hepatocellular carcinoma, when it is advanced, it makes this patient as the end-stage liver cirrhosis. Not only these complications, there may be other complications in the end-stage liver disease as well. And what are those? Acute injury, AKI, with or without HRS, adrenal failure, hepatopulmonary syndrome, portopulmonary hypertension, and cirrhotic cardiomyopathy. Then coagulopathy, malnutrition, more pronounced in this stage, hepatic hydrothorax and empyema, and hyponatremia, the sodium being less than 130 millimole. And this is the stage when the liver transplant is required. Otherwise, the median survival is less than 2 months. But remember, if the hepatocellular carcinoma is the cause of this end-stage liver disease, like advanced stage or the tumor has spread to outside the liver, then the liver transplant is not an answer in this stage as well. This is end of the story then. Just a few statistics about the major complications, the ascites. 5 to 10% of the patients in compensated cirrhosis develop ascites per year. And it has got a huge mortality, 10% mortality at 1 year and 50% mortality at 2 years. Spontaneous bacterial peritonitis, 1.5 to 3.5% in outpatients. They come with spontaneous bacterial peritonitis, and it is being recorded in more than 10% in hospitalized patients. Therefore, when a patient with ascites and liver cirrhosis is admitted, ascitic fluid must be taken to see if the patient has got infection or not. And this spontaneous bacterial peritonitis has got 20% mortality. Initially, this was more than 90%, but now this has been reduced to 20%. But 20% mortality is also a significant one. The other main complication, the second complication, which I said in my initial lecture, that 7 to 8% of the patients, they develop varices per year. And the risk of variceal hemorrhage is at 5 to 15% per year. Overall mortality with each episode of variceal hemorrhage is 15 to 25% at 6 weeks. Without secondary prophylaxis, rebleeding occurs in approximately 60 to 70% of patients, and it happens usually within 1 to 2 years of the index hemorrhagic event. Gastric varices are present in about 20% of patients with cirrhosis, and incidence of portal hypertension, gastropathy, and intestinopathy range from 30 to 45%. So variceal hemorrhage in itself is a huge complication and carries a lot of morbidity and mortality. So, how to keep cirrhotic patients alive? What should be the strategies? If you sum up the whole, every year, per year, 5 to 7% of compensated liver cirrhotic patients, they change into a decompensated one. So how to keep these patients alive? What should be the strategies? And remember, it may not be the case that you find a patient is non-cirrhotic chronic liver disease and then you are following and patient is developing compensated and the decompensated end stage. A patient can come to you at any of these stages. Rather, what the patients come to us in the clinical practice, they are mostly in the decompensated liver cirrhotic stage. Luckily, when we get them in the compensated liver cirrhosis are non-cirrhotic chronic liver disease. Unfortunately, when a patient is found or comes with non-cirrhotic chronic liver disease, they are not properly managed or followed up in most of the centers. Even in compensated liver cirrhosis, the follow-up is not that good, that desirable. Unless I'll explain in the coming slides, we ensure the proper and regular follow-ups of these patients. A patient may come to us in this stage, and after a couple of years, we may get this patient in decompensated liver cirrhosis stage or in end-stage liver cirrhosis stage. So this is very important that we should have a proper protocols for these patients to either stop the patient, put a brakes here that are compensated cirrhotic patients, they don't proceed to the decompensated liver cirrhosis patients, and even if we get a patient in decompensated liver cirrhosis, attempt should be done if liver transplant is not possible to push them back into the compensated liver cirrhosis to treat the complications event which the patient has come to us effectively and then push them back into a compensated liver cirrhosis and keep them over there. How we do that? Let's discuss that. The management principles of the management of cirrhotic patient, they are twofold. One is suppression of the etiological factors that has caused liver inflammation and cirrhosis development, like treatment of hepatitis B, hepatitis C when the PCRs are positive. Even for hepatitis B and cirrhotic patients with negative PCR, we initiate the treatment to prevent the reactivation. And of course, the alcohol-related liver cirrhosis, if the patient abstains from the alcohol and doesn't take that again, the patient's cirrhotic stage is halted or even reversed. Then targeting key factors of pathogenesis of cirrhosis, decompensation, and progression. This is the second strategy. And what strategies are included in this second way of managing these patients? To target the abnormalities in gut-liver axis by antibiotic administration. And rifaximin is showing promising results, not only confined to the hepatic encephalopathy, but also to the spontaneous bacterial peritonitis, but also to the development of portal hypertension. Then improving the disturbed systemic circulatory functions and long-term albumin administration is one of the concepts that these patients may get benefit of that. Then decreasing the inflammatory state, statins have been applied, have been used in such cases, and reducing portal hypertension by using beta blockers. Remember, beta blockers' role is not confined to the prevention of the variceal ruptures, but also the studies have shown that the early introduction of beta blockers when there is significant portal hypertension, or even if there is portal hypertension and the varices even may not have developed, they prevent the appearance of the first decompensatory event, which is ascites in most of the cases. Studies are there when they give beta blockers to patients without varices and ascites, and as a control, patients having no ascites and no varices, and over time they found that the patients who were on beta blockers but portal hypertension, both of the groups were portal hypertension patients. So the group beta blockers group, the development of ascites and varices were delayed as compared to the one where they didn't give the beta blockers. And in the beta blocker, this is the carvedilol, which has got an edge on the propranolol. So, to summarize, a cirrhotic patient needs a multidisciplinary team, a team approach, hepatologist, endoscopist, interventional radiologist at time, intensivist when the patient is admitted in the ICU, hepatobiliary surgeon. It may be a tumor resections, it may be shunt surgeries, it may be liver transplants, and supportive team. This is very, very important that the cirrhotic patient's care should be a multidisciplinary one. This is when you receive a patient in decompensated liver cirrhosis, some complications happen. What should be your approach? Because as I said, our aim is to treat that complications and then push that patient back into the compensated cirrhosis. So what should the strategies in case of treating acute event? First is they treat the primary decompensation. For example, if a patient has presented with variceal bleed, treat the decompensation. Then treat secondary complications. These bleed may have caused onset of hepatic encephalopathy because the blood is a rich source of protein. And it's a high protein may give rise to encephalopathy. There is chances of infection. There is hemodynamically instability. So the patient may come with the variceal bleed, and even in the hospital, the patient may develop hepatic encephalopathy. And then to prevent the tertiary complication, you admitted that patient in the ICU, and now you want that this patient should not aspirate, should not go into another renal failure. So when a patient comes to us with acute event, it may be either ascites, it may be variceal bleed, it may be encephalopathy, or it may be acute and chronic liver failure. The management policy should be to treat the primary decompensation, treat the secondary decompensation, and prevent the tertiary complications. So after the successful treatment of the acute event by these three measures, the next step comes prevention of the future events. So you give the secondary prophylaxis for the complication which brought the patient in, for example, variceal bleed. If the patient was not on primary prophylaxis, you start the patient on the secondary prophylaxis of variceal bleed. And you start the primary prophylaxis for the other complications like for hepatic encephalopathy, for ascites, good nutrition. For hepatic encephalopathy, you avoid the precipitating factors like constipation, like drugs. This is very, very important and the integral component of the treatment of the patients in the decompensated liver cirrhosis. And then essential components do not forget that all these patients who have been successfully treated for acute event and you ensure the prevention of the future events, you ensure that these patients should have a rest of inflammation and treat etiology. If the patient is hepatitis B, hepatitis C, or alcohol, I already discussed this. Keep these patients in child class A by improving their nutrition, the albumin, the PTINR. You keep them if they have got the ascites and encephalopathy. So treating that will keep the patient in compensated cirrhosis child class A. Ensure desirable nutritional status. This is very, very important. Promote an effective control of infections because the infections push the patient from the compensated sources to the decompensated sources. Avoidance of the hepatotoxic drugs. This is important. Surveillance for HCC and vaccination of these patients against if it is HCV patients or alcohol-induced pressure or NASH-related cirrhosis, the hepatitis B vaccination, even the hepatitis E vaccination, and the influenza vaccination. So these components, they must be offered to patient in the compensated liver cirrhosis. And if the patient is presented to you with a decompensated liver cirrhosis, then of course the story starts from the acute event management, and then these will be complementary. So these are the main steps how you will ensure that the patient remains in the compensated liver stage and does not progress to the decompensated liver stage. And if you received a patient in end-stage cirrhosis and you successfully treated the complication, you may put that patient back into decompensated and then over time to the decompensated if the luck favors that patient and you. So to summarize the whole thing, to keep the cirrhotic patients alive, you need in-time diagnosis of the case, and for that you need clinical features. Anybody can diagnose the patient is cirrhosis. In absence of the clinical features, ultrasound and labs tell us. Even if there is no clinical features, ultrasound is normal, labs are not that abnormal. FIB4, APRI, and FibroScan can tell us if my patient's liver is cirrhotic or not, and if the patient has got fibrosis or not. Then regular monitoring of the patient is very, very vital. With the help of the CTP score and MEL score, never forget to calculate these two scores, which is just a smartphone-based simple scores, and record that. Then offer prophylactic strategies to these patients of the primary prophylaxis and the secondary prophylaxis against different complications. Then preempting decompensation. Preempt if any decompensation event is going to happen and treat that before and prevent that. Then properly trained and dedicated team is important in the centers where they deal with liver cirrhosis patients. And of course, the MTD strategies must be developed. I'm sorry to say that only few centers have this MDT strategy. And to me, the MDT strategy does not mean discussion about the tumors. Even other complications do need MDT team approach. So we must develop and implement the proper protocols for those patients who are indoor and those who come to outdoor, and even at the home, domiciliary care. It's very important. We should train the attendants of the patients as well as the patient as well to be vigilant in picking up if there are impending encephalopathy or variceal bleed or taking the drugs properly and the good nutrition and all those things. So we should enforce all these three layers of care to these patients. So to sum up, my dear colleagues, I always show this picture that cirrhotic patients, they are a very delicate creature, and we need very loving care to these patients. We need extra care to these patients because they are fragile, they are very delicate, and even a minor insult to the liver may cause huge problems. So the take-home message is, liver cirrhosis has well-defined natural history. Cirrhotic patients must properly be monitored over time. Decompensation must be preempted. Success lies in the team approach. And never forget to explain the disease and its expected course to patients and relatives, and to avoid malnutrition in cirrhotic patients. With this, I thank you all, and I hope I have been able to give you the concept of how to keep cirrhotic patients alive. Thank you very much.